Hello, and my name is Dr. Paul Wylie, and I am the Chief Medical Officer of Preferred Research Partners, which is a clinical trial research company based in Little Rock for the last 20 years or so. And the purpose today in talking with you, the community at large of Little Rock and in Arkansas, is to try and bring into awareness and increase understanding about some new developments in the field of mental health, particularly the use of psychedelic medications for treatment of mood disorders. And my background is as a neuropsychiatrist. I finished my residency in 1992 and have been in private practice since that time, and then also boarded in sleep medicine for children and adults in both areas, and practiced that for about 27 years. But over the last 5 years, really my professional interest and focus has been in performing clinical trials for the reason that it's at the end of my career, it's a very intellectually stimulating activity, but it's also a way that I see where I can use the knowledge I've gained over my years of practical experience to try and really bring some new and innovative treatments, whether it's in the field of mental health or in the field of sleep or headaches or whatever other area, to the largest amount of people that I possibly can to try and improve their quality of life. So that's kind of my focus at this point. And so as part of that effort, today we have a conversation between myself and Katie Walker, and we're going to try and address some questions that a lot of people might have, both professionals as well as the community, as to what prompts interest in psychedelic research at this time. So, Katie, would you introduce yourself to the community?
Absolutely. My name's Katie Walker. I have been a therapist for over 12 years now. My specialty is in trauma, but I am very passionate, like Dr. Wylie, about innovative research. So I travel around the world to get different trainings, how to help the community, how to help people, how to provide different modalities that is going to get people fast treatment. So, the reason I'm here today, Dr. Wylie, is because not only are we both passionate about seeking how to help people in effective, fast, safe ways, but I have also been a client of yours. I have been a participant in the study for microdosing. And so that is one reason I'm here, because I am not only passionate about working, I'm also passionate about helping you spread the message of this. And also, I kind of want to grill you a little bit with all these questions that the therapist community has for you and clinical trials on psychedelics.
Well, that'd be fine. I can try my best to address them for sure. And that puts you in a very, very unique spot, Katie, as far as being both having been a participant in a clinical trial, but also having the professional background. And, what's nice, too, is that your professional background also allows you to be a staff member, right, for some of the trials. So would you like to let the community know what your level of involvement is at this point in terms of on a national organization level? And
yes, absolutely. So I was a participant in May of 2023 in the MindMed study and had such an amazing experience and how much it helped me with my own anxiety. I continued to promote it and promote Preferred Research Partner. I have a TikTok following, and I actually made a TikTok about it that gained some steam. And as a result, the CEO of MindMed reached out to me to talk to me about my experience. And they are actually flying me out to Boston this summer to be on their panel for an international conference, which is very exciting because once again, I could talk about this stuff all day. So I have a lot of different roles in this, right? As you said, I get to look at it from a professional experience as a therapist and seeing how much it has helped me. It's given me hope as a therapist. It's a privilege. You guys offered me a job to help with marketing last year. And because of that, I've been able to do a ton of marketing around the state. And now because of that, I have the privilege to now work with MindMed directly and continue to get the word out about this treatment that's hopefully to come.
Yeah. Well, congratulations on that honor and your work. And it's a pleasure to work with you and all the different aspects that we have together for sure.
Likewise.
Thank you.
One thing I want to ask you, Dr. Wylie, is there's a lot of treatments out there. There's, obviously we have SSRIs and stuff like that. I kind of want to know a little bit about your history you've been in this profession a lot longer than me, and I would love to know your history of what it looked like then versus now, versus there's a lot of understandings and misconceptions about psychedelics. So I just am curious. We live in a southern state. There's a lot of could be controversy around the psychedelic medicine. So I just kind of want to know your history about where you're from, where it used to be like, where you're going, and why in the world are you so passionate about psychedelics?
Sure. Okay. Well, that takes me back, and it's a good place to start, because really when I graduated from residency and medical school, the medication treatment that was available, Katie, for treatment of depression and or anxiety was really limited to what was known then as the tricyclic antidepressants. They were effective for at least 30 to 40% of people in terms of treatment, but they contained a lot of side effects. One of the primary ones is that they are very sedating, and they'd cause dry mouth, dry eyes, slowed down bowel function, things like that. So somewhere early in my career, between like 1992 and 1996, I can't remember the exact year now, but Prozac came out. And boy, was that a leap forward in terms of our ability to help people with depression. Not perfect by any chance, and we've learned a lot about Prozac as well as all the molecules that have followed since then, all the kind of Me Too's that have varied over time in terms of how long they last, how often they have to be dosed. They varied in their side effect profiles. But Prozac came out and was a big step forward in that it's a serotonin-specific reuptake inhibitor, and it was much more strongly affecting the serotonin receptors in our nervous system, which we found was kind of a step forward in terms of being more effective in treating depression. So, historically there was Prozac, and then there was Zoloft, and a variety of other medicines came along. And then the next kind of step forward was the use of serotonin-specific reuptake inhibitors combined with a norepinephrine reuptake inhibitor. So they became known as SN, as in nickel RIs. And that was another step forward in terms of treatment, because they were able to help some people with mood and anxiety disorders that a plain serotonin medication did not. And, that brings up the point that no one human's brain is the same. And so there's, I don't think, ever going to be one treatment that really affects every single human being in a positive way. We really have to design a treatment regimen for someone's specific brain. It'd be nice if we get to the point scientifically where we could do a little blood test or something like that and say, okay, you have brain G instead of brain R, and therefore this is the protocol. And I do think we'll get there closer and closer to it over the next 10 to 20 years, because in a lot of clinical trials, there's some genetic testing going on to figure out why someone responded well to a certain new medication and why someone else didn't. So anyway, it was the SNRIs. And once again, we got a new subgroup of people with depression that we were able to help. But once again, we realized that, still only about 30 to 40% of people responded. We realized that there was relapse. We realized that you can't just give those medications to people for 6 weeks and say, okay, you're going to be fine. It would often take months to a year. And then at one point, recommendations came out where if someone was on a recurrent depressive episode, they needed to be on those medications for 2 years before we ever thought about tapering them off at that point in time. So that's a long time for someone to have to take medication from that standpoint. And then, over that time, I'm going to pause away from medications for a little bit, but over that time, there was a lot of new developments in therapy for depression that I'm going to, want you to talk about as well too. All of a sudden this whole term cognitive behavioral therapy came along, and then there was cognitive behavioral therapy for a bunch of indications, and then we had trauma specific therapy. So concomitant with that, there's been a lot of changes and improvements in therapy that we'll ask you to talk about that have joined together conjunctively with the use of medications to allow for better and more complete treatment, and more longer lasting treatment, and specifically in helping resist relapse for sure. So the next thing that came along in medications was, I think, the use of adjunctive medications. So we started learning that, gosh, if we added in medication, for example, like aripiprazole to an antidepressant, well, we'd get another 10 to 12% improvement in some people in their depression or mood or anxiety disorder or what other mental health disorder they might be struggling with. And so that was kind of the next thing. And so there's still a lot of active research going on in the use of adjunctive medicine, particularly in how they help people who not only have their first episode of depression, but who have recurrent depressive episodes, or the term we now use as well as what's called treatment-resistant depression, where individuals have a less than 50% and a lot of people even less than a 25% response to their particular antidepressant or combination of antidepressants or antidepressant plus a adjunctive agent plus therapy at the same time, right? So all of a sudden, we get to the point where we start to, I don't want to say discover, because the effects really of psychedelics were discovered years ago in the 60s and 70s, but we get to the point where we start to revisit what compounds may help people with mood and anxiety disorders. And I think society gets to the point where it's accepting more so of this type of research. And we start to pull back in what are known as the psychedelic type compounds. And that process really started with ketamine, various forms of it, S-ketamine, such as Spravato. And then, there's all sorts of Native American Indians or South American compounds, mushrooms. And so now we're looking at psilocybin, active research going on at Preferred Research Partners with that compound. We're looking at LSD in the treatment of anxiety disorders and depressive disorders, and active research going on right now, again, at Preferred Research Partners. We're also looking at some other psychedelic compounds that can be administered in different ways. So, for example, if you take a pill, well, it may take 3 hours to get into the system, and then it may last a long time. So how do we redesign pills to get in within an hour and wear off quicker, but yet produce the same beneficial effect for depression? So we're looking at changing the formulation around. That could even include a dissolvable film under the tongue, which we have, again, another clinical trial coming up with a psychedelic for that. So we're looking at various forms from that standpoint. But so that's the preface to the what big difference does psychedelic makes. But psychedelic compounds, let's look at it this way. If you take a SSRI or an SNRI, they work by attaching to the serotonin and or norepinephrine receptors, and we're not 100% sure how they work down to the detail, but what they do is promote neuron growth, okay? The thing is, though, is they do so very slowly, so you have to take them every day. Sometimes you have to take them twice a day. You have to take them every day we don't usually see the response to depression in clinical trials. When we're measuring a new medication, we don't even, sorry, bumping my microphone. We don't even worry about measuring a response for 6 weeks. Okay. Yeah. And then we realize that maybe full response might be 12 weeks out. And then we're saying, okay, we need to take a look at where they're at 6 months, 9 months, a year, and have them continue on it. And maybe even, as I mentioned before, up to 2 years to get full effect. So the problem is they produce changes in brain chemistry very slowly and incompletely, and they take a long time, and then they have to be taken to maintain. And that brings up an interesting phrase, which I just used, which I think the mental health community is moving away for, which is for years we used the term chemical imbalance.
Yes.
I have a chemical imbalance. And maybe so, but what causes a chemical imbalance? Okay. And we now know that individuals with depression and anxiety and PTSD and other mental health disorders, could be OCD. And I'm going to even extend this because I think we're going to move the use of psychedelics into this area. I'm going to talk about individuals who have degenerative brain disease.
Yeah.
So I foresee this as Parkinson's disease, Alzheimer's, frontotemporal dementia, Lewy body disease, all that sort of stuff, most of whom have a concomitant mood or cognitive disorder. But all of those diseases, and we now put depression, anxiety, PTSD in that area, as there has been dysfunction of the neural circuitry. In fact, we're going to go so far as to say there has been damage, to the neural circuitry of the brain, particularly in what's known as the prefrontal cortex of our brain. So it's not just that things are imbalanced, it's actually a worse situation in the sense that, and I don't think people with depression commonly think, well, I've got depression. It's a big change to say, I have a damaged area of my brain that I need to go get treatment for. And that's how we're going to be looking at this in the future. And the damage isn't mean to be a negative thing toward that person. I think it really changes how an individual looks at, I'm suffering from a problem, right? Well, it's not just me, I'm a bad person, I've got some damage, right? So the beauty of psychedelics, in particular, some of the ones we're looking at, for example, ketamine, S-ketamine, take a little longer lot of dosing. But the beautiful thing about psilocybin and even LSD is that they work very quickly. We're talking about a change in mood within 24 hours, okay? And we're talking about sustained duration of effect, where a single dose in a single afternoon, we've got people off antidepressants or off anti-anxiety medicines for 9 months to a year now, if not getting up to a year and a half for some people that have never had to go back dosing again. And the way they work is they attach to the 5-HT2A serotonin receptors, which are very unique receptors that are responsible for brain neuroplasticity, which means the ability of a brain nerve cell to change and grow, okay? So the way to picture that is picture your brain nerve cell as being a tree. So you've got the trunk of the tree, you've got all these branches off there, and then you've got the leaves, okay? And people who have depression or anxiety or PTSD, or if they have a dementia of some type, have lost the leaves, and then they've actually had their branches pruned, okay? And that means that nerve cell can't really talk to other nerve cells effectively, which results in a chemical imbalance, but we've now moved to what's caused the chemical imbalance, right? So it's a degeneration of neurons, and the ability of psychedelics to cross into the brain and uniquely stimulate and rapidly stimulate the 5-HT2A receptor to cause neuronal growth and increased connectivity is amazing. It's amazing how quick it is. It's amazing how long it lasts. And my gosh, you asked me, this has been a hell of a long answer, right, to why are you so passionate about it? But my gosh, can we get someone who's got depression and anxiety to take a single dose of this medication and say that, in particular with the support of a skilled therapist, this is the only dose you're going to have to maybe take for the next 6 months to a year, and that's it. And in between, you're not going to be partially treated at 25%.
Yes.
You're going to be 75 to 99% better than what you were. That's the long-winded answer to what we're working on.
I geek out so much when I hear this because when I think about prior to ever being a participant in one of your studies, right? As someone with extremely high anxiety, obviously I'm a therapist. I know all the skills you can use. My daily regimen, not only did I have my weekly therapy, but I was doing, I had my SSRI. I did literally daily yoga, if not 2 times a day, plus just the stuff that meditation every day, ice pack on the chest, somatic exercises just to maintain baseline. And I'm not sure I would call it baseline. I remember the first time we met and you were telling me about the study and I said, sign me up. And you're like, you don't know anything about it. And I said, I know enough to know that I'm struggling, and whatever you have to offer, if it can give me a glimmer of hope, I'll take it. And that's because, but here I was doing everything. And I think the cool thing about it, right, is I never thought that I would get off my SSRI. That wasn't an option. And, and what I'm hearing you say now is like, that's what we're trying to move to is, or at least where it's not every single day. And so here I was, someone on it every day, doing every skill, and my anxiety was still through the roof. And so fast forward, I know the scariest part of the trial for me was coming off that medication, and you guys safely tapered me down, and you guys have an incredible medical team who watched and handled that. And then on dosing day, I remember coming in, and I remember, first of all, praying I didn't get a placebo, right? Yes. That's probably everyone's fear. And thankfully I did not. And that, that experience is, I don't have words for dosing day because of how, but the one thing I can tell you that I just remember sitting up at one point, and this was more when I was coming down, and I cried, and I had my two therapists in the room who were helping or monitoring, and they were like, "Why are you crying, Katie?" And I said, "A little piece of me feels scared because prior to being dosed, it was not uncommon to have." Seriously, over 50 streams of consciousness, right? Like I'm sitting here with you, but I'm worried about my kids, but also what's for dinner, and also where's my husband, and also I have to pick up this, and did I move the clothes over? And I was just functioning, and I just sat up, and I was like, I have one stream of consciousness right now, and I don't know what to do with this. And, that did not last. Obviously, you're going to see the most effects on that, but I never, still to this day, we're coming on, May will be 2 years since I was dosed. I still have never gone back to that. I went 10 months after my dosing day without being on medication. I did get back on my medication. However, I'm still at the lowest dose they offer. And I wish I could say I still did daily yoga and all my stuff. So I am functioning significantly better than I was after that one dose, and not having to pile on all the things to keep me just baseline. So it's truly amazing.
Well, warms my heart to hear you say that. So I'm happy for you from that standpoint. You were a participant, Katie, in one of the initial trials of the MindMed, which is microdosing of the LSD, and that was a dose-finding trial where we tried different doses and placebo. And in that particular trial, there was just one opportunity, and you don't know whether you were going to get placebo or the middle dose or the high dose. And the nice thing is we're beyond that particular clinical trial now. So for both of our trials for MindMed, which would be use of microdosing LSD for depression, microdosing LSD for generalized anxiety disorder, but also for our USONA trial, which is with psilocybin, which is another trial we have, and for the additional trial we have coming up. All of these trials are now able to offer, since we're aware of the dose, extension studies.
That's amazing.
So every one of these trials now has the opportunity for repeated dosing and repeated exposure if needed for up to a year after one completes the initial trial. So now even if somebody would happen to end up on placebo, generally within 6 weeks, they have access to the full high dose of medication in the extension trial, guaranteed from that standpoint, and we continue to monitor individuals for safety going forward. So
I think that's important you said, because I think there's a misconception within the community for clinical trials. Like people might be hesitant to send their clients to you, a therapist, because, or a psychiatrist, because they don't want them pulled off all their medicine, given a placebo, and then good luck in the world. And that's not what you guys do.
So let's talk about coming off medicine. It's kind of interesting. First off, these trials are specifically for individuals not in their first depression episode, although I think we'll get to that trial down the line. But these specific trials are for people who have treatment-resistant depression. So these are, or treatment-resistant anxiety from that standpoint.
Yes.
So these are individuals already for whom the medication is only doing 0 to 25% or less than 50% from that standpoint. So, coming off a medication that's only, helping with 30% of your symptoms, but you're still got 70% dysfunction during the day and impact on your life is not necessarily a bad thing when you look at, well, my opportunity for being in a clinical trial, particularly if it has the guaranteed extension study, is going to be that I've got a 100% chance of getting better.
Yes.
At about a 75 to 99% chance of getting access to the medicine that gets me this much better. And so we haven't had anybody really respond to less than that from that standpoint. So it's remarkable. So, and the other thing I think that's important is it's not good to put people in a clinical trial if it jeopardizes their safety. So we very carefully look at individuals who have a tendency towards self-harm or, thoughts of self-harm or things like that. And those are not someone that you really want to be pulling off medication to be in an investigational clinical trial, or individuals who have a lot of instability. And for this clinical trial, it's very specific toward, recurrent major depression and recurrent and generalized anxiety disorder. All of them are. So for the example, it's not right now for someone who has bipolar disorder. It's not right now for someone who's got significant active PTSD. It's not right now for someone who might have a personality disorder that they struggle with, although once again, I think in the future, the opportunity for neuronal growth there. It's not for someone who has dementia or any sort of brain cognitive problem at this point, although once again, I delightfully look forward to the future for that. So from a safety standpoint, it's our job to maintain that. And one of the first things I ever tell people when I come in is, hey, thanks for your interest in a clinical trial. How did you find out about this trial? What is your interest in the trial? And I said, well, let me tell you what my role in this trial is. And my role in the trial is to maintain subject safety, and that's it. And that's what I do full time. I don't have any other clinical practice at this point. So my focus is on maintaining the safety and the accuracy of data for individuals who participate in a clinical trial, and even after they're done with the trial, making sure that they have access to ongoing treatment. So that brings up a question that I have for you, which is, for a lot of these trials, they all have inclusion-exclusion criteria, and one of the inclusion criteria is that they can be in therapy, for depression or anxiety, but they have to be established in therapy, generally for somewhere around 6 weeks or something like that. And they can't have a change in therapy while they're in the trial, and they can't start, while they're in the trial from that standpoint, because those are all things that throw off the measurements. This is a scientific experiment to prove that if we change nothing else, it's just exposure to the medication, an effective treatment. And so now once it gets FDA approved, then, those boundaries, won't be there from that standpoint. But what's it like to serve, and how do you approach serving as a therapist to someone who might participate in a clinical trial?
Oh, that's a great question. First, try and not geek out too hard because, I just want to ask all the questions. I love it. But so for me, I think it's obviously going to differ therapist to therapist. I make a lot of referrals to you guys. I do want to highlight super quick before I answer a lot of my friends in the therapeutic community who refer to you will often text me or say, none of my clients get accepted. And that's funny, but also it really speaks to your dedication that you are committed to not the numbers. Yeah. You are committed to finding the correct people. And I love that.
Yeah. Not punitive toward people. If they're not accepted, that's that's not any sort of negative statement toward the client or the person. I'd like them to view that as, gosh, that doctor and his whole staff are very safety oriented, but also oriented toward doing very good clinical research. Because we owe that to the people who are going to use this compound 10 years down the line. If we don't do it right now and follow very close safety and strict guidelines now, then the person who accesses it 10 years down the road could have problems because of what we failed to protect or didn't do now.
And so I've always said it speaks to you guys' integrity and that you are always going to watch out for the subject. And so I wanted to give that feedback. But when it comes to me as just a therapist involved with a participant in one of your clinical trials, I do utilize CBT. A lot of my approach, though, is very body-based now. You know, CBT is very powerful, but just like medications, we have learned CBT gets you this far, but then what's the next step? And research says the next step now is body-based stuff. Somatic is huge. Somatic, teaching people about their nervous system, teaching people, you know, deep breaths, of course, but why are deep breaths helpful? Or isn't it crazy that you can put ice on your chest for 15 or more minutes and that helps shift you into your parasympathetic nervous system instead of, you know, those people who can't sit there and breathe or spiraling. But this is a, you know, anatomic response that helps. And so I think it's really encouraging that therapy is moving forward alongside of what you guys are doing. So we are going at this in two different groundbreaking modalities to help change the nervous system's perspective, to help grow branches and leaves and all the things you're talking about over there.
Regrow branches and leaves.
Yes. And so for me personally, usually when I have a client come in or someone who participates in one of your clinical trials, something I do is obviously I monitor what are we doing, what are they continuing to use the same coping skills. I kind of push what you guys push, right? Like I don't want anything else to change. I want, you know, if their coping skill is that they're riding a bike 3 times a week, I'm going to check in on that. But maybe are they enjoying that more? Do they notice it's helping? So they are doing these things, but what is the relief they're seeing? I do a lot of forms as well, you know, the PHQ-9 or various things every now and then to check on that, but mainly just monitoring the coping skills that I've given them, the body-based stuff that I've given them, the somatic and all of that I have taught. How much difference is it making effect now? Right. Yeah. And with the psychedelic, what kind of life-changing are we seeing now? And it is huge.
Yep. Yeah, I think giving somebody management skills, I have always throughout my career used the concept of people having a toolbox.
Yes.
And so if you open up your toolbox and all you have in the toolbox is a hammer for dealing with your problem, and the solution is to hit yourself in the head with a hammer, then there's problems and there's side effects. And, you know, there's days when you don't need the hammer. The hammer might be good some days, but maybe every day you don't need the hammer. So what a beautiful thing is it through the use of medication to be able to facilitate someone's brain to be able to get greater benefit from the tools that you teach them, so that when they work with Katie and they open up their toolbox, having been with you, they look in there and say, well, today's a sandpaper day, you know, or today is just a ruler day, you know.
Right.
That's the beauty of it. And research has demonstrated that, and I think this is an important point to make, research has looked at use of psychedelics alone, okay? But research has already looked at the use of psychedelics with therapy, okay? So the FDA has not allowed any of these companies really in testing these medications to do so without there being therapy support in the dosing session, trained therapy support, and they prefer there to be therapist support before and afterwards on an ongoing basis. And it's been demonstrated to make it somewhere around at least 20% more effective, and particularly in terms of duration of mechanism of action and prevention of relapse, so that you giving people these tools in their toolbox is incredibly important. So from that standpoint,
to build off that, I love it, right? Because as a therapist, we work together, right? Because as a therapist, I'm sitting here growing this toolbox, but then every session they come back to me and they're like, I locked myself out of my toolbox. I have everything in there, but it actually doesn't open, or I misplaced it, or I'm spiraling. So I feel like this helps them actually look and utilize that toolbox.
Or I'm too anxious when I open my toolbox. I can't figure out what tool I should even use, and I get stuck in a spiral of thinking. So.
Yes, or you're like me, right? Where I use every single tool in the toolbox every single day, and now I'm like,
and you wish you could go to Home Depot and get a different tool.
Absolutely.
Right?
I get me all of them.
I would guess, based off your experience, that your eager for this to become commercially available, perhaps, and
absolutely.
redose at some point.
I would love that.
Yeah, you can't be in this new clinical trial having already been exposed once away. That's once again, that's the way we maintain cleanness of data, so we're not sending the same person who's had a positive response through again, right? But I'm assuming you would look at that from that standpoint.
Yeah, so I am curious. Let's say this goes mainstream one day, right?
Yeah.
Which is the goal, which is the hope.
Yeah.
What will that look like? You know, you mentioned at this point, what do we think that will look like?
Yeah. Well, I'm hoping that in 2 years or less, we're looking at FDA approval, which would be great. I'm hoping from that standpoint of, and we've already got ketamine and esketamine, but they're not quite as immediately effective and they're not as consistently effective, and their duration of action isn't nearly as long as like the psilocybin or even the LSD is right now. So I think in the future, what it will look like, probably, I would say, Katie, it's going to be very similar to some of the requirements that the FDA put forth for when a medication called Xyrem was developed for treatment of excessive daytime sleepiness and narcolepsy. So, highly controlled substance. Only one pharmacy in the entire U.S. distributes it. To be a prescriber, you have to be able to pass a course and go through a certain amount of training in order to be able to prescribe it. You have to have certain things in place in your clinic and your staff, such as yourself, has to have a certain amount of training in working with psychedelics to be able to provide support and ongoing therapy. So I think that we'll see these expert psychedelic clinics develop that have some very highly trained staff that can be dedicated to this effort, because it's going to take probably more effort than what is required now for example, Spravato. Whereas Spravato, you can go in and get dosed with this ketamine and nasal spray, and you have to be monitored for blood pressure and things like that.
Yes.
But there's not a lot of requirement for kind of what comes afterwards, okay? And it's not ketamine, not quite the same level of controlled substance as psilocybin or LSD is because of their hallucinogenic properties. So I see that being the role, which I think is good. I think the training is great. I also see that this is just the first generation of psychedelics and what's to come. So when you get LSD or psilocybin attaching to the 5-HT2A receptor, it very strongly and uniquely stimulates it, even more so than the serotonin specific, which is why they work quicker and more and create more plasticity. But the problem is that same receptor also is what creates hallucinations, illusions, imagining things, creates maybe perceptual disturbances, anxiety, some nausea as well, which can all be kind of the mild side effects that can occur very transiently during a dosing day session that not everybody has, but can have that. And then 99% of those are gone after dosing day from that standpoint. Yeah. So, but what if we can develop what I will call the second generation of these psychoplastic psychedelics? In other words, that means psychedelics that change the brain neurochemistry. What if we can develop a generation there that doesn't have the hallucinogenic side effect? So I think what's to come is that while initially I think it may take these special clinics, I think what's to come is it's going to be just like any other pill, in that someone's going to be able to dose by themselves at home because they're not going to have some of the psychedelic hallucinogenic effects. Right?
Wow.
Or if we talk specifically about the use of this in PTSD, which we don't have those trials going on now, I think MindMed will move to that, and I think USONA will go to that. Yeah, that's next on their list.
I'm waiting on it.
after they get FDA approved. But the potential there for going into some dark memories is higher, right? There's a reason for the PTSD, whether that's a tornado blew up my house or whether that's I was assaulted or, whatever.
Yes.
So there's always, I think, going to need to be some support there. And so even if it can be a home dose type thing, I really think that we're always going to have, very important to have the role of the therapist to process it, depending on the disorder that's being addressed by the use of the medication. So I think that's what's to come next down the line after this.
That's so exciting. Thinking about it, truly, it's mind-blowing, which is what I love about you, right? You're so future-focused in thinking. So that makes me think of, we know the answer to this question, what I'm about to ask, but for the sense of safety, the psychedelics that you guys are giving out, why can't someone go do this on the street?
Oh, yeah. Well, I guess they could, in terms of availability of, magic mushrooms and LSD and that sort of stuff. But there's a danger to it. Yeah. And the danger to it is all of these medications affect, blood pressure and autonomic nervous system functioning. There's a danger with the hallucinations and the illusions. So even if someone is not going and taking these compounds with a recreational purpose in mind, outside of the 70s and stuff, if they're going with specifically purpose to, I want to try and self-treat my depression or anxiety, there's medical support that's needed during the dosing session. I'm always around. The therapists are around. Yes. We're monitoring blood pressure and everything else.
Yes.
I may have to respond with the use of what we call a rescue medication if someone gets overwhelmed by their experiences from that standpoint. And that's not necessarily hallucinations. I'm talking about just getting overwhelmed by what comes flooding out in their processing from that standpoint. So there's a safety. And so to do that and try and do that at home, it's one thing if you have depression or anxiety. It's another thing to do that if you have PTSD. You can end up in some dark places. And I think people have self-harmed who have done that. And so it's all about, once again, all about safety at this point. But the other answer to the question is because it's going to produce a incomplete, inadequate experience generally. And they're not going to get the most out of their effort from that standpoint. Clearly demonstrated research that working with a therapist such as yourself before, during, and after is ideal from that standpoint.
Because like you said with you, I was nervous about being dosed, right? But you guys, in fact, I did have hallucinations. That is something I experienced. And I was very frustrated that you guys kept checking my blood pressure while I was trying to enjoy, but you have the supports in place because once again, safety is priority for you guys.
Yeah. Yeah. And there's been a lot of talk recently amongst psychedelic researchers about how do we optimize the therapeutic experience. And so it's not an optimal therapeutic experience for us to go in and check your blood pressure, but we're having to combine that with safety.
Yes.
But ideally, the optimal therapeutic experience would be we wouldn't necessarily have to do that, but the clinical trial requires it. And there are all sorts of other things that optimize the clinical experience. For example, there are very specific researched musical selections and themes that these pharmaceutical companies have selected to optimize the therapeutic experience, but also yet not to cause problems. It's probably not the time you want to listen to Ozzy Osbourne hit Crazy Train, right? So there's that. We also know that now they're talking about optimization of the experience afterwards. So what does someone go home to? You don't really want to go home to childcare. You really would like to go home to a warm environment. You really don't want to go home to an environment where the TV's on and someone, has Jason on at Halloween, right? And even the next morning, a support environment. So we're getting more and more expertise for that to optimize the entire therapeutic experience from 6 to 8 weeks ahead of time to even what occurs in the immediate 24 to 48 hours afterwards, but also how do you optimize the therapeutic experience for the next year. Yeah. And so if someone's going to go through this time and effort and, it takes about 2 days out of their life from that standpoint at this point to do that, it'd be nice to optimize the experience so they get, for their family, for their friends, for themselves personally, they get the best experience possible and the longest acting type experience possible and the most complete recovery possible.
Yes, I loved the, MindMed had set up a playlist and had, given different recommendations, like putting on the blindfold, and there was and I love that. It definitely changed the experience. So we've talked a lot today. I brought a list of questions from the therapeutic community.
Yeah.
We've answered a lot of them today.
Okay.
I'm going to go through some of them, but I do think we've covered a lot. But just, I don't think this goes, even needs to be addressed, because we've talked about the safeguards. A lot of people wanted to know about safeguards and how we protect clients. Is there anything else? I feel like we've covered that a lot. But
Well, I think that I could add in that every clinical trial protocol requires blood work be done, which again is offered free by the pharmaceutical company, not us, but paid for by the pharmaceutical company sponsor. EKG, physical exams, specialized genetic testing, all sorts of things like that in order to promote safety. So once again, sometimes we get people through and we find out and say, you've got a liver problem that, what's going on that maybe we need to be addressed, or something else. Or we find out that they've got a electrocardiographic problem that would not be safe for them to participate. So there are certainly additional safety measures. My ongoing availability, our coordinators' ongoing availability, and also the ongoing availability and the comfort we have that the individual has access to a therapist, such as what they can get through you and your company, Indigo Health, right, and other therapists in our community.
Yes.
That also is a measure of safety from that standpoint. So definitely have a team in place to promote that. When someone doses with the psychedelic, particularly in a clinical trial, it's not one and done. There's a follow-up the next day, okay? Yes. There's a follow-up about 3 days after that. There's a follow-up a week after that. There's a follow-up 2 weeks after that. And then maybe it goes to every month and we see how things go. And particularly in an extension study, there might be a once-a-month visit, whether in person or by phone or whatever, to see if someone is perhaps relapsing and requalifies. But all of those have safety questionnaires with them. How are you doing in terms of thoughts of harming yourself? Has anything come up? Has anything changed? Are you on any new over-the-counter medications that might be no-nos? Are you on any new medicines? Have you had an upper respiratory infection since we last saw you? All sorts of type of things that we ask in follow-up visits to protect safety. I don't want to leave out, go back and see your treating psychiatrist and keep them informed as to what's going on. And we will do that as well and keep the therapists informed as to what's going on. So the idea behind clinical trials is not to relieve the relationship with a psychiatrist. Yes. As you've pointed out, even for yourself, there may be a need to get back on medication when the clinical trial expires. Before perhaps one of these compounds becomes available, or when it becomes available, it'd be really nice if their psychiatrist was interested, he or she, in being a dosing. Yeah. So that relationship needs to stay right there, because mental health is not I'm done and I can forget about this for the rest of my life. It's a dynamic management process over the course of someone's life. Yeah.
And it's so important you said that, right? Because I think a lot of people think that if they refer clients, then they're going to lose that client, but it's the exact opposite. No. You're like, no, we need you to stay in this.
I've been on the other end of that. I had my own mental health inpatient practice, outpatient practice for adults, for children's, my own sleep medicine practice for adults and kids. And so, I've been on that and fully understand it as a private practice doc and docs that have worked within hospital systems of making sure that participation in a clinical trial doesn't, hopefully doesn't interfere with the ongoing doctor-patient relationship. So I am exquisitely sensitive to that as having been on the other end of things for sure.
Yes, which is kind of why you looped me in, right? One of the reasons to help network, to spread the message, like he's not here to get your clients. You have respect for the treatment team. You want that treatment team in place before these people come to see you. And so you're not coming in and taking over per se. You're just an additional support. And you even said you want to collaborate with these therapists. You would love to work with them. You would love to review, them review document. We've talked about this. And so I think that is so important to know, that the therapist and the psychiatrist team still need to be involved.
Absolutely. Yep.
Yeah.
We've got other therapists we work with, as you know.
Yes.
There's a Reed Ballantyne out there who has an incredible amount of psychedelic experience,
Yes.
who we work actively with. There's Karen Fry.
Yes.
And then there's Ken Counts. Ken's a PhD neuropsychologist that has 40 years of practice experience as well as personal experience. And so these are individuals you work with. And then, Katie, if you could talk a little bit about what you do at Indigo Health, your therapist, but also about your in-state network that you reach out to and communicate with.
Yeah, so Indigo Counseling, Dr. Wiley.
Okay.
And we have a team of 8 therapists. And so, once again, we're super passionate about different modalities. And so everyone on our team tends to have some sort of different experience, whether it's in somatic work, EMDR, eating disorder, substance abuse. We want to make sure we offer a variety of things that are not just the standard talk therapy, right? And so we see an array of clients, and my biggest thing I tell people what Indigo is passionate about, along with the people you mentioned who I love dearly in the therapeutic community, is just the quality of care, right? I tell people all the time, I would rather have a small clinic as long as I know my therapists are providing top-notch care, and that's kind of what we're big on, is making sure we are providing the best cutting-edge treatment there is out there. So a few more questions. We've answered a lot of these. Let's see. How are participants' rights and confidentiality protected?
Well, first off, clinical trials are very, very highly regulated by the FDA and what are called good clinical practices. So there's really nothing more paramount these days than making sure, again, it's back to the safety. And in this case, it could be an individual's rights and safety being protected. And so that means confidentiality of information. It means that we're not the only ones overseeing the trial as well. So, some of the information, blood labs and other things information goes back to the pharmaceutical company, which then goes to the FDA. But all that is blinded. But the pharmaceutical company, a whole nother separate company called a contract research organization, and the FDA, they're all oversighting every single site that participates in these studies and making sure that safety is enforced. So we have sometimes twice monthly visits from someone who comes and reviews every single page of data, every single consent form. Has it been signed and initialed? Do you show indication that you've given the person enough time to read the consent form? Have you explained it to them? All of that is oversighted. So it's not just us. There's 4 layers of oversight for patient safety from that standpoint. So you mentioned something that I want to just throw in before the next question, which is you mentioned eating disorders.
Yes.
And then you asked me before about what do you see the future of psychedelics? Well, there's some other things we've discovered about if you undergo psychedelic treatment. Eating disorders, obsessive compulsive disorders, okay, drug and alcohol addiction. Lately in the news, which we do some research with the GLP-1s, which are the metabolic medicines like Mounjaro, and we're working on the successor molecule to Mounjaro right now, have some research. But all those medications have been shown, interestingly, as kind of an aside to improve those things. But we now know that psychedelics, whether that's the target problem or not, improves it. And so individuals, for example, with OCD, their OCD may still be there, but they're just not as intrusive and overwhelming to them. Same thing with eating disorders. And I think the use of psychedelics in the future is also going to go towards substance abuse and reducing the need for substance abuse in a different way. We do that now with treatment. We do it now with therapy, but there's no treatment out there for substance disorders that regrows your brain connections that would cause you to not have the desire. And I think we're moving toward that in the future as well. So pretty cool.
Yeah, I'm really speechless on that. I'm sitting here thinking of how that could help so many clients and people I love dearly, right? That is. Yeah. So all of this groundbreaking research and a top-notch team who puts patient safety first. This has got to cost a lot of money to be a client, to be a participant in one of your studies.
No. In fact, it earns you money. It costs money for the pharmaceutical company that's developing the trial, and they pay us to get volunteers, but they pay us to maintain this safety because they can't be on the ground floor in different states of doing this. And for these psychedelic trials, there's probably only going to be about maybe 15 sites across the U.S. that are going to do these trials. So first off, you're very carefully selected as a site. They come in person, they review your processes, they look at the study you performed before, were there safety violations or other things? If so, they kick you out. You're just done. They do it politely, but you're just not offered the next chance, right? And so they're oversighting safety from that standpoint. So they're overlooking all of this toward ensuring patient safety and privacy, and they pay for us for that services. But a participant in a clinical trial, I don't like to talk about them being patients, although it's habit to use that name because there's not a traditional doctor-patient relationship. And I don't like to, we've used the word subjects, which I'm, but that implies you're looking at a monkey in a cage in some ways. And so we're not that, but they are participants or volunteers in a medical research trial. And as such, as volunteers, we are respectful of their time and effort. And it takes time and effort on their part. So even though there's benefit, maybe to the participant, if you're in a placebo-controlled trial, you might get benefit, you might not. And they're informed about that. And they know the odds of getting the medicine or not. Now, the beauty of the trials we have now is we know there's an extension trial. So at some point, even if someone's on placebo for the first 6 weeks, we know they're going to have access to the medicine should they need it down the line, right? But they're compensated by the pharmaceutical company for their time and effort, for travel. Sometimes it requires overnight stays in hotels, for food, for visits to come in for clinic, compensated for blood work and all that sort of stuff. So we try not to make it that other than their time and effort and engagement, that a participant in a clinical trial is not out money. Yes. We can't pay for everything per se because the pharmaceutical companies bump up against FDA regulations, international, what's called good clinical practices, where you cannot pay an individual to be a volunteer in a clinical trial a coercive amount of money. There must be some volunteer component where I volunteered to do this. And even in our kid trials, you have to ask the child, are you okay with being a volunteer in this? And so even though they also get compensated from that standpoint for participating, there always is a volunteer aspect. But we try to minimize the impact on someone financially. Now, if you look at the benefit of being in a clinical trial and you say, well, take, for example, when Spravato or nasal esketamine come out, well, sometimes it's tough to access that in the community. Insurances won't pay for it.
Yes.
It's too expensive. It takes a while to get accepted, et cetera. But there are times when individuals have participated in a number of our clinical trials that the value of treatment to them they've received would A, never have been available in the community, but B, if it was, and once it does become that way, probably exceeds $50,000 to $100,000 depending on what clinical trial they were in. So an individual participant always has to look at, well, I'm getting this investigational compound for free. I'm getting access, free blood work, free physical exams, free oversight, free monitoring. So while they do get compensated in addition to that, there's a lot of financial benefit to being in a trial. So.
Yes. So Preferred Research Partners has 2 locations. You guys have Little Rock and you have Fayetteville.
Fayetteville, yes.
And so if a client comes in and noting, right, we've already noted that the clinical trials you do can be hard to get into because they look for very specific sites. There might be 15 across the U.S. So if you're saying, someone is within a decent driving distance of one of your sites and they go through you guys' criteria to become a participant, there is the chance that they could get compensated for overnight stay at hotels and stuff like that.
Yeah, not just a chance. That's pretty well guaranteed.
Yes.
Yeah. So, for example, in our Northwest Arkansas, we have both sites approved for the MindMed depression study. We also have it approved, both sites, for the USONA psilocybin study. Yes. And we're working on getting the generalized anxiety disorder study up there. So individuals in the state of Arkansas can choose either site from that standpoint. up there, our principal investigator is Dr. Renee Henderson, who has trained under me for 7 years now, and she's the principal investigator up there, and I'm the sub-investigator, so I back her up at that. And so that's our sister site at this point. I'll give you an example. We've had pharmaceutical companies pay to actually have a service drive people in from Memphis. We've had people compensated to come in to see us from Oklahoma City. We've had individuals who, because of their treatment, for example, one was a medication to make them sleepy or to keep them awake, where we don't really want them going home. So we have hotels nearby, and the pharmaceutical company has compensated them for multiple nights in a hotel if they have to have 2 or 3 visits. So absolutely, the pharmaceutical company will compensate for time and gas spent if someone's a couple hours away, and that could include even from out of state, southern Missouri. We've had people come up from El Dorado and even into Texas and Texarkana and that for our studies. So the pharmaceutical company will take care of them. As a volunteer participant, they're very eager and thankful for someone's willingness to take the medication, and so they'll absolutely take care of that without a doubt. We've done it over and over again from that standpoint. So, yeah, for sure.
Dr. Wylie, I can't thank you enough. Me personally, the things I've seen and the things I'm excited about. I am so thankful that PRP that you are so passionate and that we're lucky enough to have PRP in Arkansas, that you are dedicated to this. And I'm thankful you have looped me in, and I've got to take an exciting, both involved and now sideline study to help promote this. But I am so pumped about things PRP is doing now and going to continue to do.
Well, Katie, thanks. And reciprocally, we can't do it without partners and professional partners, and then individuals who, partner with us who've been participants. We have other individuals who partners with us as well too for other things. So it kind of takes a team to promote general improvement in the humankind's well-being. And you're looking at 300 million people worldwide with depressive episodes, 16 million people every year. In the U.S., you're looking at maybe 23 million people a year with generalized anxiety disorder. So this is stuff that you got to get excited about, the ability to affect so many people's lives in a positive manner. So to partner with you on that is a privilege. So thanks.
Thank you so much.
Yep, you bet.